Welcome to the Talking Brains podcast. I'm your host, Dr. Stephanie Sarkis at stephaniesarkis.com. Talking Brains is a podcast about the brain, therapy, and how it relates to you. Go ahead and take a minute to hit that subscribe button and leave a review. It's appreciated. Today's guest is Dr. Rick Moskovitz. Dr. Moskovitz and I met over 20 years ago, and I have always appreciated his insight. Today we'll be talking about how memories are formed, particularly during trauma. We'll also talk about state-dependent learning and how it relates to blackout drinking. I found this to be a particularly enlightening discussion of why and how the brain remembers trauma. Rick Moskovitz, MD, is a Harvard-educated psychiatrist and vintage being who had the privilege for 37 years of sharing in his patients' stories while leading his own imperfect life. He is the author of Lost in the Mirror, an inside look at borderline personality disorder, and Carousel Music, a novel based on the controversy around recovered memories and psychotherapy. He left practice to write fiction that explores the psychological consequences of living in a world of expanding possibilities. The Methuselarity Transformation is his first science fiction work. So I'm speaking with Dr. Moskovitz about memory and how memories are created and trauma and memory. And we talked yesterday a little bit about how trauma can make it so that your brain remembers some things and not others. So I was wondering if you could speak a little more to that.
Well, first of all, I think it's important to understand that memory is very subjective. At best, it's a complex piece of fiction with elements of truth folded in. It's more like a painting than a photograph. It's more like a drama than a documentary. It's something that is constructed not at one moment, but over many moments, sometimes separated by years. As we remember things, we tend to bring our memories out of storage where they're stored in the brain and either contemplate the memory or relate the memory to another person or in some way operate upon the memory. But each time that we do, before the memory goes back into storage, it's inevitably altered in some way, not deliberately, but incrementally over time. So memories tend to evolve and can never be entirely trusted to be factual. Traumatic memories, even more so. Traumatic memories are affected by factors, including the intense emotions that are evoked in the course of trauma, the outpouring of neurotransmitters, mostly stimulatory neurotransmitters during such experiences, and the effects that these factors have on the recording of the memory. And the effects are going to vary with the salience of the elements of the memory. So, for example, with an intense trauma, the outpouring of epinephrine and norepinephrine is likely to create an intense image of some elements of the trauma while obscuring some of the neighborhood images.
So we were talking about how when you interview somebody post-trauma, that
Yes.
it's very common to remember some pieces, but not all of them.
But not all of them, yes. There's going to be a lot of variance in which parts of the images are remembered. One analogy that comes to mind, when I go to the eye doctor these days, I'm screened for cataracts. And one of the things that they do is they have you look at the eye chart and shine a very intense light in your eye and see whether or not you can still read the eye chart. Unfortunately, as we get older, it becomes harder and harder to do so. And the parts of the image around the periphery blur first, and the images in the center blur last. But in the face of a very, very intense stimulus, it's difficult sometimes to perceive and record a less intense and salient stimulus like a letter in an eye chart. So some of the neighborhood events and neighborhood details of a traumatic memory can get obscured and overwhelmed by the intensity of the central aspects of the memory. So when I said that memory is more like a painting than a photograph, one might say that a traumatic memory is more like a caricature, in which the most salient aspects of the memory jump out at you, while all of the fine details may be more obscured.
And that has to do with the fight, flight, or freeze mechanism. I think we talked about that when your brain is in that state of heightened arousal, that it is it accurate to say that it leaves some things to the side so it can focus on the survival?
Yes. Particularly when your life is threatened or you feel like your life is threatened, a lot of the surroundings tend to go away, and you're focused most intensely on whatever it is that's threatening your life. And you talk about fight, flight, and freeze. I think most of the lay public is aware of the fight or flight reaction, but more recently, the freeze reaction has been well documented by researchers. And in the animal world, that means that when an animal is threatened with imminent death, one of their automatic reactions may be to freeze and appear dead. And that accomplishes a number of things. First of all, it tends to anesthetize them so that if they do get eaten, it doesn't hurt. And it also can trick the predator into thinking that they're dead, and they're less apt to eat dead prey. So, and then once the threat is over, the animal may jump up and scamper off into the woods as if nothing happened. So that's the freeze reaction, and that's been documented. I believe the book is Waking the Tiger by Peter Levine. He gives a beautiful description of the freeze reaction.
And when someone's in a trauma, like I think we were talking about Dr. Ford yesterday, that if you're in a trauma where your life is threatened and you're able to escape, you escape as quickly as you can,
right.
And your brain tries to make some kind of sense out of what just happened. But again, you may remember your life being threatened and then leaving, but you may not remember details like what the room looked like or
right.
that kind of thing. And that's completely normal for that to happen.
Right. And if you're still processing the experience and processing the memory, that again may overwhelm the details of what happens next. So if you're running off into the woods or running off down the street, you may not notice the details of the street or the character of the houses or those kinds of details, while your brain is still overwhelmed by stimulatory neurotransmitters and processing what just happened to you.
Right. And we were talking about too that if Dr. Ford is interviewed again, that details may change, but that doesn't change the underlying trauma that happened to her.
Exactly. In fact, the details probably will change because memory isn't perfect, and recall from one episode of telling to another is not perfect. It's not like a recording. Again, it's a story, and we try to make the narrative of our lives as consistent as possible in order to develop our identity, but it is a narrative, and it does change, and that doesn't invalidate it. It doesn't invalidate the central aspects of the story.
Right. And we talked about, too, that if you do ask someone about the trauma, you also have to look at other aspects, such as any eyewitness or any corroborating testimony or a person's character, because the memory itself is, I would say, it's probably the foundation, and then you have the structure above that lending, I guess, credence to the memory, would you say, or?
Well, there are a lot of things that lend credence to a memory. I think conversely, there are a number of things that might tend to invalidate a memory. So, back in the 80s and 90s, there was something called recovered memories therapy. And that was based on an assumption by some therapists that certain symptoms were inevitably founded in trauma. So they set about in rather deliberate ways to identify the trauma, to elicit the trauma. And in some hands, that led to structured interviews that were highly suggestive and tended to contaminate some of the memories or pseudo-memories that were elicited. So whether or not memories are elicited in an open-ended way or via directed interviews, that's a very important aspect, and the context in which the memories are elicited. So if memories occur spontaneously in the course of treatment, for example, they're more likely to be valid than memories that are elicited in response to directed interviews. The other thing about memory, one of the questions back then was, is it possible to have repressed memories that haven't been available on a continuing basis, emerge later in life and still be valid? And I think the answer to that is yes. I think there are lots of reasons why memories get repressed, particularly memories of intense emotional experiences. One aspect of that is a defense mechanism that tends to protect us from pain. So in some patients with trauma, the memory is not continuous. Now, how can memories exist but not be available to consciousness? Well, I can give you a more mundane example that comes from my own aging brain. There are lots and lots of situations in which I find myself fishing for information that I know is there somewhere, the tip of the tongue kind of phenomenon, but I can't find it. And as we've discussed, my wife and I can sometimes collaborate in eliciting a memory. So, for example, one of us might say, gee, you remember that movie in which the two guys jumped off the cliff and there were these two good-looking actors and, what were their names? And, we think about it, we forget about it for a while, and then we might come back to it and one of us say, Robert. And then a little while later, the other one would say Redford, and the memory, and then the full memory would get reconstructed. So the information is there, and traumatic memories, the information may be there somewhere buried inside, but there needs to be a way of getting at it. One way of thinking about it is that in the case of some traumatic memories, it's as though the memory were encoded in a zip file, and that zip file might have a password. And when the right password comes up, the file can be opened and the contents looked at. And the password can come in a lot of different ways. For example, one way it might be watching a story on the news about someone who's had a similar experience. And that might be the password to some people's zip files. So there are a lot of different ways that old memories that haven't been thought of maybe for decades can suddenly become new and vibrant and available.
And yesterday when you're talking about gaslighting and how people that are gaslighters, great manipulators, that they can figure out your password and get into that file and corrupt it, basically, it sounded like.
Well, yeah, perhaps in some ways. I'm not sure that analogy applies there, but but as we look at memories as an evolving structure, as we look at memories as a painting that is being painted and revised and painted over, over the course of time, the gaslighter has an opportunity to direct the hand that's holding the brush and change the image with powerful input.
Can you have someone that has been manipulated to that point, can they somehow take off those layers of pain and go back to the original memory through therapy? Or how exactly does that work for them to uncover what was, I guess, assigned to their memory by someone manipulative? Is there a way to do that?
Well, that's a good question. I imagine in some cases there are, and in other cases there aren't. It depends on how heavily the new layers of paint have been layered on.
Okay.
And the authority and influence of the person who's doing the manipulation. So if someone is intensely bonded to someone who may be an abuser and may be someone, that has a great deal of control over their lives, that person's ability to obscure the underlying truth might be greater than a random stranger's.
So if you have someone that's been a victim or survivor of abuse, is the part of the key of therapy is to maybe not just help uncover those layers, but also to accept that maybe some things have been altered and that it was a false altering of the memory. Is that part of it, getting to that acceptance that, I guess, that the meta thinking about the memory, that the memory isn't exactly what they thought it was?
Yeah, I think that's reasonable.
Okay.
As we look at this from the standpoint of therapists, what we're trying to do is understand the patient's dynamics. We're trying to help them construct a narrative of their life that makes sense for them, that helps them be at peace with who they are, that helps them understand their identity. And we do that as best we can with the information that we mutually with our patients have available to us. It's not perfect, but ideally we want to be able to create a narrative that the patient can wind up feeling at peace with.
And so it has a lot to do with the person's ability to be open to that, open to discussing, which is also very difficult for people who've been through a trauma, but it's kind of the saying, what you put into it's what you get out of it. But you have to be willing to put some trust in the therapist.
Correct.
To work with something so traumatic.
Yeah, there needs to be trust that your information will be handled sensitively.
Right, and that's why we have so many tight restrictions and ethics and regulations on what we can say, and also the confidentiality process too. And I've noticed that it always helps to, and you probably know this too, that when we first meet with somebody, we're going to develop rapport first. We're not going to get right into the meat of what's going on.
Right.
And if you could speak a little to that and how that helps the therapeutic process, developing rapport and how we build trust and let people know that people can have their confidence in us, that we are not going to disclose to other people or judge. So if you could speak a little bit to how the rapport part helps in the therapeutic process.
That has to do with the emotional connection, the affective connection between therapist and patient. That there needs to be a sense of empathy. There needs to be some appreciation that what they're saying, even if their recall may be imperfect, is believed by the therapist and trusted and valued. Conversely, one can certainly break that trust by excessive skepticism, by arguing back with the patient about the validity of their beliefs, especially early on in the therapeutic process, or by, worst case scenario, mocking them for their memories. That's certainly a way to crash the therapeutic alliance.
And when you speak about arguing back, if you could explain a little bit about the difference between that and confronting, gentle confronting, because later on in the therapeutic process, sometimes as therapists, we kind of call people out on a maladaptive behavior, but usually it's further on down the line in therapy. So if you could kind of describe the difference between arguing back, which is inappropriate,
Sure,
and gentle confrontation.
Well, first of all, some of that depends on the stage of therapy. So early on, I would tend to err on the side of being more accepting and more validating. Although if somebody comes up with something makes no sense at all, I might, certainly confront them early on. But I think there's a difference between confronting a patient's reality and confronting their behaviors and choices. So on the one hand, not believing a memory is possibly an injurious kind of interaction, but that doesn't mean that letting a patient know that a decision that they've made may have consequences that they haven't foreseen, that may be maladaptive, that may bring consequences down the line that they would not welcome. That's a different kind of confrontation, and that happens all the time in therapy.
Right, and that's not saying that what you went through is not true. It's valid. It's just that we're talking about, again, the behavior separate from the traumatic event.
Yes.
And the maladaptive behaviors from that. So, because I have had people ask me that question, what's the difference between a therapist that's a quote-unquote bad therapist and a quote-unquote good therapist?
Yeah.
And it's not that a good therapist never confronts you. It's they're confronting you about maladaptive behaviors, not the thing that happened to you. So I just want to clarify that for people who have asked about that.
And they may tell you about a traumatic event and then at a different time tell you about some behavior that you perceive may have derived from the traumatic event that's maladaptive. And helping them to connect that can be a very valuable confrontation.
And if you could get a little more about what kind of maladaptive behaviors do you see after a trauma? Are there general maladaptive behaviors that you see? Is there something that's across all forms of trauma that you see particular maladaptive behaviors?
No, that's a big question.
Okay.
I think, I think that there are a number of things that cut across all trauma. There's a tendency to avoid situations that remind you of the trauma, and that can sometimes mean maladaptive choices. Sometimes there's a tendency to almost repeat the situations that surrounded the trauma. Freud called it the repetition compulsion, going back and repeating as kind of a way of seeing if there's a way of making it come out differently. And ending up getting re-traumatized, and that's maladaptive. There's self-injurious behaviors, sometimes dramatic, deliberate self-injurious behaviors that can derive from traumatic experiences. And certainly a whole host of interpersonal behaviors that are anathema to the development of intimacy and the development of solid relationships. That derive from trauma. So there's a huge spectrum of ways in which trauma leads to one's life falling apart or dancing on the edge of a knife. By the way, there's just something came to mind that I don't want to forget here, because sort of how my memory works. If I don't tell you now, it might disappear.
Yeah, mine does that too.
And it has to do with confidentiality and trust. One of the important things to me when I was recording my recollections of sessions with patients in their records is protecting their confidentiality, not including things that could be really embarrassing to them if it were to come out, let's say, in a legal proceeding, like a divorce or a lawsuit, or things that happen later on to patients that uncover their medical records. There's a special case of that in which I was particularly cognizant of not including things that could potentially be defamatory to others in their lives. So if a patient identified someone to me that had done something egregious, whether to them or around them, it would not be something, their name, they might be referred to, but their name would not appear in the medical record. I would consider that a breach of confidentiality of someone that I don't know, that I've never met. So, and that's kind of germane to the situation that we see in the news, in that the accuser, Christine Ford, did talk about this incident years ago to her therapist.
And two therapists, I believe.
Two therapists, yeah. But I think somewhere it came out that the name was not in the therapist's notes. And what I want to say is that's absolutely normal and correct.
Exactly.
Name should not be in the therapist's notes. I would not have put the name in the therapist's notes. That's just the way we do it.
Right, and we were trained in that very thoroughly, how to do that. That we do not want to, make judgment ahead of the fact. Right. And so that's very typical, because I've heard that from people. Well, this name wasn't in there. I'm like, well, that's how we do stuff. We aren't going to put everybody's name in. We talk about themes rather than particular people.
Right, exactly.
And I was just reading something after we talked yesterday about Dr. Ford, that when they were looking at houses, she wanted a house with 2 front doors on it because she wanted to be able to escape. And I noticed that too, that people will have outcomes of trauma that we may not see as trauma related. If we're outside of a clinical profession. So I found that very interesting, because I've seen that with people, that they'll make sure that they know where all the exit routes are if they're somewhere. And so that's another thing that I found interesting, that adds validity to her claims, that she had displayed these behaviors much prior to being in front of the committee. And also we were talking too about, and you had talked about this earlier in this recording, that how you ask somebody about the trauma makes a big difference in their recollection and their accuracy. And that, I remember you said that open-ended questions are very important. Yes. And like you said, not the leading questions.
Correct.
And that's why we need to be especially trained in how to do that. And also, when we talk about the freeze mechanism, we're also talking about how your brain doesn't let you choose which reaction you have to trauma, whether it's fight, flight, or freeze.
It's pretty automatic, yeah.
And could you talk about a little bit about why that's so automatic?
Why that's so automatic?
Yeah, like why would your brain pick one over the other?
Well, first of all, it's survival. Yeah. Our brain somehow chooses what's most likely to lead to survival, and it goes back to our animal origins, to evolution. Our reactions under threat aren't really very different from the reaction of a gazelle threatened by a leopard. The essence of the experience is the same, and the gazelle certainly doesn't choose. The gazelle doesn't go through a cognitive sequence. How am I going to best escape this? It's instinctual. And I think our response to intense threat is still largely instinctual. Certainly we have more of a capacity to think and plot escape, but at the height of threat, we may not. And in the example, in the news, once the opportunity for flight occurred, she took it. Because that was the most likely means of survival at that point.
Right. So your brain can switch in a microsecond.
Right.
To something else. Yeah.
And of course, you can't flee if you're being held down.
So, right. Which was her. She's alleging that he put his hand over her mouth and held her down. Right. So that's where the freeze mechanism comes in.
So there's freeze, and certainly may have been an effort to fight, but she was overwhelmed by size and numbers and factors that were just way beyond her control.
Right. And I think also with memory of trauma too, people will remember things that don't always seem to fit with the trauma. Like, she remembered people laughing. And I had someone say to me, well, why would she remember that and not remember these other aspects? But it's incongruous to her experience, is that her life was being threatened and people were laughing. And that's why her brain remembered that so clearly. So I think it doesn't always make sense to people why the brain remembers some things and not others. But it's not like we get to choose if we're under threat.
Well, and again, if you look at the evolutionary aspect of it, the laughter of human predators kind of like the growling of animal predators. You know, you remember the sounds that are most threatening to you.
Yeah, absolutely. That makes a lot of sense. So we're going to talk a little bit about blackouts. That has become a pertinent issue because of the Kavanaugh hearings. And Dr. Moskovitz and I were talking yesterday about state-dependent learning. That if you are in an inebriated state when an event occurs, you may not be able to remember it unless you're, again, in the inebriated state. So if you could speak a little bit more into state-dependent learning, Dr. Moskovitz.
Okay. Well, alcoholic blackouts are kind of a special case of state-dependent learning. In general, as we record memories, our memories are recorded in an overall environment that may include the situation that we're in, the time of day, our emotional state, and our chemical state. And all of these things may be pertinent to our ability later to retrieve the memories. So in general, it's easier to retrieve memories in states that are closest possible approximation to the state in which the memory was laid down. As an example, I used to tell my students that if they have a big exam that they're studying for, that they may do their best in recalling the answers if they study in the lecture hall in which the exam is later going to be taken. And what's more, if they have taken any medication to enhance their studying, that's also a particular state that they're in, and they may have difficulty remembering the information if they're not under the influence of the same medication when they take the exam. So it's a very, very complex interplay of internal and external circumstances with the laying down of memories. Alcoholic blackouts are a very special case of that, in which things that are experienced during intense intoxication may not be remembered when sober. And they may not ever be remembered again ever, but it's also possible that they could emerge into awareness if the person is again in the similar state of intoxication. And even more so if they're in that state of intoxication in the setting in which the event occurred. Amytal interviews, which go way back into the last century, were a way of, called truth serum. It was a way of sometimes eliciting forgotten memories. And one aspect of that is that creates a state of relaxation, but another aspect may be that amytal and alcohol have kind of similar effects. And, for some people, memories that occurred under the influence of alcohol may be elicited under the influence of amytal or IV Valiant. Or similar substances. So, that's kind of my understanding of alcoholic blackouts, that it's a very special case of state-dependent learning in which the event occurring under intense intoxication is no longer available when sober.
So someone that's interviewed about an event may have either a foggy recollection or no recollection at all, but the event may have still happened.
Correct.
Okay.
Correct. And they may or may not have a record of it somewhere in their brain that can be accessed at some future time with special means.
So again, the Zipfile concept.
Yes.
So this may be a Zipfile. So under hypnosis or amytal or some other form of, or in another blackout state, that, well, I guess in blackouts you wouldn't really recall memories, but
right.
But if you are in a somewhat inebriated state, you may start recalling that situation, or if you're around the same people, or
exactly. So this is the zip file in which the password may in part be getting drunk again.
Mm-hmm. Right, which doesn't mean we're advocating that if you're doing testimony that you're drunk, but
no.
But it also means that something may have happened, but that person really may not have a recollection of it because of their mental state at the time.
Correct.
Yeah.
Correct. And it may be so deeply buried they could even pass a lie detector test.
Mm-hmm. Which we could have a whole podcast about that too, and how inaccurate those can be.
Yeah.
So yeah, that's a whole other hour. But so just to recap, the state dependent learning means that if you are prone to blackouts and you have something happen, or if you commit an assault during that time, it's possible that your mind has blocked it when you are in a sober state, or you just remember bits and pieces, and it doesn't quite seem like an assault because you just remember locations or people there. You don't remember the actual act, but again, that doesn't mean it didn't happen.
Correct.
In wrapping up, what would you like to let everybody know about memory, and in particular, if you want to speak about Dr. Ford's experience, and also people that may have had a recurrence of PTSD symptoms from their trauma? What advice or suggestions could you give to them if they are having a recurrence of traumatic memories after watching the testimony?
Well, certainly watching this testimony is likely to have been triggering for many, many, many people with similar experiences. And, coming forward and talking about it, is certainly one means of adaptation. I think that to the extent that the emergence of traumatic memories causes pain, getting treatment makes a great deal of sense, as a first thing. Confide, if you can, in someone close to you that you trust. Get to formal treatment as quickly as possible, and hopefully to find treatments that help to put the trauma to rest in as rapid and effective a way as possible. In my own practice, one of the most useful tools I had in addressing trauma was a treatment called EMDR, eye movement desensitization and reprocessing. It's a cognitive behavioral approach that helps the person to kind of rework the meaning of the trauma in their lives and the meaning of the trauma to their identity, and combines that with some neural processing that can help put the pain to rest in rather dramatic fashion, often within 1 to a dozen sessions, as opposed to years and years of conventional therapy. So that's one of a number of treatments that are available now for addressing trauma in truly effective ways, almost surgically from the standpoint of the psychotherapeutic tools that we have.
And I also add too that EMDR has had quite a bit of support and research. Very good, yes. Well-run, good methodology and studies. And there's one study that found that EMDR had the same success as cognitive behavioral therapy, but in half the amount of sessions.
Yes.
So I think that's, like you said, it's pretty rapid and very surgical how it can heal the trauma. And that doesn't mean the trauma entirely goes away, but it gives some relief from the daily kind of assault that the memories have on you.
Yeah, particularly the negative self-messages that we tell ourselves about the trauma and about being a victim. Those messages can change, and we learn to understand them differently. So, for example, in the case of someone who's been through a trauma that we presume that Dr. Ford went through, she may have gone through decades of her life feeling helpless, feeling like a victim, feeling like there are situations that she has no control over. I've had patients with very similar experiences come around to focusing more on how they escaped and realizing that they, in fact, did save their own lives and that they didn't experience the devastating damage that was trying to be inflicted on them, and that they triumphed in the end, and that was very empowering.
Right, and just the term survivor, I tend to switch more into that than victim, because I think it expresses the fact that what an amazing person you are, that you went through this and you're here today.
Yes.
And that you're in therapy, because that's a real sign of courage to talk to someone that you pretty much don't know about your personal stuff, especially when it's that personal and that traumatic. So I think one of the things that people that aren't clinicians, I'd like to send the message to them is that you may not know us, but we are invested in your well-being, and we try to again foster that trust early on. That again we are held to really high standards for our behavior and confidentiality. Because I know, especially when you've been through a trauma and you've reached that base level of your trust being completely violated, it's a really courageous thing to go in and get help for it.
Yes, absolutely.
So, anything that you'd like to conclude with? This has been fascinating, and thank you very much.
I think we've covered the most important points. This discussion has been perhaps more topical than some of your than some of your podcasts may be, because of the intense experience that we're all going through as we observe the political drama that's unfolding around us. And I think it's important, not to take these comments as an absolute judgment one way or another of what happened, or whose truth prevails, but an understanding more that this is a very complex situation, and arriving at absolute truth is often next to impossible, and that we have to come to some understanding of what's enough. We come to some understanding of what the threshold should be for making these important decisions.
Well, thank you very much. I really appreciate it, Dr. Moskovitz.
Okay. Glad to have had the opportunity to talk with you.
And that concludes another episode of Talking Brains. You can go ahead and hit that subscribe button and give us a rating. And again, that was Dr. Rick Moskovitz. His books are Lost in the Mirror, and that's an inside look at borderline personality disorder. Carousel Music, a novel based on the controversy around recovered memories. And also his latest book is Methuselah Transformation. That's his first science fiction work. So again, you can reach me at stephaniesarkis.com, and thank you for listening.